Well, it's about capnography. How many people use capnography right now? Good. Classes on capnography, you understand it? Yeah, it's pretty good. It's really very easy, but capnography is the best tool since the EKG. And I say that very boldly. I truly believe that because, I mean, we think about why. Let's look at a patient, just a normal patient. Let's say we have a 72-year-old male who is cool, pale, diaphoretic, complaining of chest pain, shortness of breath. You know, I mean, chest pain is 10 on a 10. We look at him and we're like, okay, this guy is having some kind of a cardiac event, right? So we look at our partner. We're starting to work. Let's get a non-rebreather, 15 liters a minute on board. Let's go ahead and get some vital signs. Let's get an IV. Let's get the monitor on him. And, sir, tell me about your pain. When did it come about? How does it feel? Describe it. We do our OPQRST. We're assessing our patient now, right? So our partners are doing everything. We're doing everything. And we're thinking, all right, this guy's probably having an MI. And as we're talking to them and we're maybe getting some blood pressures or an IV, whatever it is, all of a sudden our partner kind of nudges us and says, hey. And then we look at the monitor and we're like, oh, my gosh, that's VTAC. And the sense of urgency just went from about 30% to 100. I mean, the pucker effect, you know what I'm talking about, now just went to 100, you know, because it's VTAC. So we're like, okay, conscious, unconscious, stable, unstable. Do we give lidocaine? Do we give amiodarone? How are we going to treat this? So now, you see how the monitor helped you be able to heighten the sense of emergency? All right, let's look at another scenario. Got a 72-year-old male, cool, pale, diaphoretic, complaining of shortness of breath. His lips are cyanotic. We're now starting to treat this guy. Okay, let's get a non-rebreather, 15 liters a minute. Let's go ahead and get our IV. Let's get our blood pressure. Let's get the monitor on him. And I'll tell you that based on what I see on capnography, what I see on the waveform, and what I see on the number, gives me the same sense of urgency. It literally does. I know very quickly, all right, I've got to do something. Is this guy in respiratory distress? Is he in respiratory failure? Do I now need to put on CPAP? Do I need to bag him? You know, I mean, because very quickly he could go into arrest. You see what I mean? So capnography to me is just as important as an EKG when I'm treating my patient. All right. What we're going to learn here, we're going to describe the normal perfusion of the respiratory system very quickly. We're also going to describe normal capnography values and waveforms, and then we're going to identify abnormal waveforms, their causes, and then just standard treatment options. You obviously have to follow your medical director's protocols, but we'll talk a little bit about treatment, okay? Now, understanding capnography, you have to understand the pathophys. How I learn, it's the KISS principle to me. Keep it simple, stupid. That is me. As simple as I can make this, the better I understand it. So what I do is I compare the body to my car, okay? I literally do. You've got 3 things to make your car run. Okay, number 1, you have to have gasoline. If you don't have gasoline in your car, then the car's not going to run. Right? So that's the same way with the body. You have to have oxygen in order to make the body survive. If you don't have oxygen, you're dead, period. I mean, you can do the best CPR, the best IV, the best medicines, the most expensive medicines, all of this stuff. But if you don't have an airway, don't give them oxygen, they're dead. Number 2, you have to have a motor in the car. You have to be able to literally get the gasoline into the engine, combust the gasoline to make the piston turn, and to make the car go. If you don't have an engine, the car's not going to go, right? I mean, you may have a full tank of gasoline in the car, but if you don't have a motor, the car's not running. Make sense? All right. Perfusion. Your body has to turn the oxygen into carbon dioxide. It has to perfuse it. If the body can't turn the oxygen into carbon dioxide, the body's dead. It's useless. It's literally, you could be 100% saturated on your pulse oximetry of oxygen, but yet if you can't turn it into carbon dioxide, it's useless. It doesn't do the body any good. The body is dead. And then number 3, you have to have a good exhaust system in the car. If you put a potato in the tailpipe, the car won't run. I did that when I was a kid. My dad about killed me, because I did that. I remember that to this day. He was not very happy with me. So with the body, if you now put a potato in the tailpipe, if you obstruct the exhalation, the CO2 going away from the body, then something's bad going to happen to the body. Whether it's a mucus plug, whether it's bronchoconstriction, it doesn't matter. You're either going to inhibit the release release of carbon dioxide. You see what I mean? So it is that simple. I compare it to my car, and then I understand the body. So now, understanding that, let's look at normal and abnormal values. You have to know what normal is before you can pick up what abnormal is, right? So we've got to understand how the body is working and then what it's going to put on the waveform. In the number itself, we've got to understand what's going on in the body. So normal waveforms, normal capnography waveforms should be nice and square. Okay? They should not be rounded. They should not be shark-finned. They should be nice and square. This is the only time in your life that it's good to be square. Dun-dun-dun. Bad joke, I know, but you're not going to forget it, okay? So it's kind of like understanding pharmacology. You know, alpha constricts, beta dilates, same thing here. Square is good, rounded or shark-finned is bad. The normal value is 35 to 45 millimeters per mercury. Okay, so it's measured in millimeters per mercury. 35 to 45 is good. That's the normal range. Okay, now we know that it can go low. We know that it can go high. So can millimeters per mercury go above a value of 100? Of course it can. Our systolic blood pressure is 120. So now granted, that's really, really high. Pulse oximetry, can pulse oximetry go above 100? No, because it's been percentage, right? 100% is the best that you can get. So it can go above 100, but my gosh, that's high. It's really, really high. So 35 to 45 is normal. All right. Above 45, high number, high acid. Low number, low acid. Make sense? So anything above 45 is typically showing you high carbon dioxide level. That's too high a number of CO2. Anything below 35 is going to be low carbon dioxide. Now remember, capnography is only measuring the amount of CO2 that is right here, that is coming out of the mouth. We like to say it measures perfusion and it measures all this other stuff. Yeah, kind of, but it really is measuring the amount of CO2 that is literally coming out of the mouth, okay? Your capnography, it literally is specific to CO2. You know that pulse oximetry measures oxygen, the amount that the hemoglobin is saturated with oxygen, but not just oxygen. It also measures another gas, doesn't it? What's that? CO, carbon monoxide. So if they have a carbon monoxide poison patient and you put pulse oximetry on them, they'll read 100. Period. But what you don't see is it may only be 5% with oxygen and 95% saturated with carbon monoxide. Capnography measures carbon dioxide, not oxygen, not nothing, just carbon dioxide. That's what's so good about it. All right, so we know that it is nice and square. Understanding the body. When we breathe in, okay, when we inhale, okay, how much CO2 am I releasing from my body? Zero. None whatsoever. So the sensor should read zero. It should be nice and flat line. Let me go back to that one waveform here. It should be nothing. Going across measures time. Going up and down measures millimeters per mercury of CO2. So as long as I'm inhaling, there's no CO2 being released from my body, so it should stay zero flatline. Then all of a sudden, I exhale. When I exhale, now remember, when I take a breath, all right, the only perfusion that is taking place is in the alveoli, not from the mouth and nares to right above the alveoli. That's called dead air space. The amount of air that's from the nares in the mouth to right above the alveoli, the bronchioles, are called dead air space, about 150 cc's of air, okay? So on the first split second of exhalation, that first 150 cc's of air still has the same amount of CO2 that's in the atmosphere, which is relatively zero. So the first split second of your exhaled air is still going to read zero. It will be flatline. Then all of a sudden the alveolar air hits. When the alveolar air hits, it is automatically the 35 to 45 or lower or higher, whatever the body has done, and that's what's going to hit the sensor. So that's why immediately, just like that, it's going to go to the 35 to 45 millimeters per mercury, creating this sharp vertical line straight up to the 35 to 45, and then as long as I exhale, it will stay at that level, whatever the perfusion was in the alveoli. And then all of a sudden, I take another breath. And when I inhale, it goes right back down to 0, and immediately, sharp vertical line, straight back down to baseline, continues until you repeat the process. See how simple it is? I mean, the body, the normal perfusion, the normal respirations of the body should create a nice square waveform, not shark fin, not rounded. Okay, let's look at the abnormal. Now, if it is abnormal, there's probably a problem, whether it's a respiratory problem, whether it's a problem with the body, or whether it's an equipment problem, an equipment malfunction, but there is a problem. If it's not square, there is a problem. So look at this waveform. You tell me, what's wrong with that waveform? We know that it should be nice and square. It doesn't go to baseline. So that should, when I'm inhaling now, I'm now inhaling, the CO2 should completely disappear, just like that, and go to 0. But all of a sudden, while I'm inhaling, I'm still inhaling 10 millimeters per mercury of CO2. So I am rebreathing CO2. Either the body is rebreathing the CO2, the machine is not able to get rid of the exhaust. You see what I mean? So as I'm inhaling. So you remember the old-time treatment of hyperventilation, panic attack? You gave them a paper sack to breathe in? That's what would cause this. That's one thing that would cause the rebreathing CO2. All right? So now we look at a sample monitor. That's all in PowerPoint, by the way. Nobody gave me that. I kind of made that little PowerPoint thing. I think it did pretty good. If you look at the Philips monitor, it did fairly well. But it kind of continues to rise. So if the exhaust port on the machine is occluded, then the machine will continue to keep the CO2, and it'll finally be at the 35 to 45, whatever the body is releasing, and it'll just end up being a flat line there. So that's one problem. That's one little increasing. All right, so let's do this. Let's say that we have a 42-year-old female who had a seizure. And when we get there, she's postictal. She's laying on the ground. You know your postictal patients, how they're got that deep, rapid respiration because they weren't breathing very well during the seizure. And now when you get there, let's say that some first responders were there. They have the patient on a non-rebreather. And you know how they're going to suck that non-rebreather dry no matter how much you turn it up? Let's say that they only have it turned up to 6 liters a minute. So now they're rebreathing the CO2. So what would we do for that? Turn the oxygen up, turn it up. So just look at the machine, try to figure out, okay, that's what's going on. How do I fix that? All right, what's wrong with this waveform? That's not square. It should be nice and square, right? That's a delayed upstroke. So that right there indicates bronchoconstriction. This is your asthmatic patient. This is where the bronchi. Remember in your A&P of the body, the smooth muscles are wrapped around the bronchioles. They're not really wrapped around the alveoli. So when you have bronchoconstriction, you're literally constricting the passageway to get air to the alveolar sacs. Does that make sense? I think of the airway like grapes. Here I go with my KISS principle again to me. I think of the lungs, the respiratory system, just like I do grapes, and I love grapes. Oh my gosh, I love red grapes, green grapes, seeded grapes. I don't care. I just like grapes. But you hold the stem at the very top of the grapes, and it's fairly large, but then it continues to break down into smaller, and then there's the grape on the end. The grape has a very thin membrane, outer membrane, that holds the juice and everything inside of it. So anyway, you see what I'm saying to me? The respiratory system, you've got your stems, you've got your bronchioles, and they go down into little finer bronchioles, and then finally to the alveolar sacs, where the nutrients are, where the gas exchange actually occurs. The smooth muscle is wrapped around the stems, not around the alveolar sacs, not around the grapes. So when you have bronchoconstriction, it is narrowing the airflow to get the air to the alveoli and also get it out of the alveoli. You see what I'm saying? So now they're having to force that air out of their lungs. So in the very beginning of their exhalation, they may only be able to release 17 millimeters per mercury, 12 millimeters per mercury. And as they continue to exhale, they finally get up to 42. And then they inhale again, and it drops right back down. That's a shark-finned waveform. That indicates bronchoconstriction. Now, if that rounds, they're air trapping. Air trapping happens in asthma and COPDers and emphysema patients. So not only are they having a problem getting the air out in the beginning of their exhalation, they're also having a problem getting rid of it in the end of their exhalation, so it now rounds on the back end of it too. Does that make sense? Rounded waveforms, that's bad news, man. I mean, that's truly, I would typically say, that if you see a shark fin waveform, that is probably respiratory distress. And you can just supplement their oxygen with a nebulized albuterol treatment, some type of bronchodilator. But if it rounds, if your asthmatic patient, your COPD or your emphysema patient, if it now starts to round, they're moving into failure. They're now getting into really, really bad problems. And if you don't take over their respirations or do something like CPAP along with some bronchodilators, they're going to end up stop breathing. They're going to go into respiratory arrest, and that we don't want them to go there. All right. So here's our sample monitor. We're looking at the monitor, and we're looking at our CO2. We still have those shark-finned waveforms there. And then we're looking up at the end-tidal CO2, and that is the 60. Okay, so it gives us a good indicator. The capnometer is the digital readout, and then the capnograph is the graph itself. Put those together, that's capnography. I like both of them. I don't want to just see the meter number, just the meter number, because that's at the end tidal. Okay, so I want to see it all. I want the waveform and I want the number too. So what we need to do for bronchoconstriction is give bronchodilators. Okay, so either with a nebulized treatment, if they're still in just respiratory distress, or if they have moved into respiratory failure or right there on the verge, then the best treatment for them in your CHF type of patient would be CPAP with albuterol. I mean, literally put it together. Anyway, all right, let's look at another one. What's wrong with this waveform? The last part of it, that's a prolonged phase 4, the last waveform. So remember, I'm now inhaling. I mean, this is truly at the beginning of inhalation. And it should drop straight vertically down, back down to zero. There should not be a little bit of CO2 in the airway as I'm inhaling. What that indicates is that your cuff is not inflated good enough, or in your pediatric patient that has non-cuffed tubes, the tube is too small. Maybe your pediatric needed a 4.0 ET tube, and now, and you put a 3 in. You put a 3 tube in, and it's not large enough. So as you bag in air, not only is the air going into the lungs, but it's also forcing the CO2 around the tube and through the sensor so it can pick it up. Okay, so that may give you a good indication that your tube is too small. Now, let me ask you this. We look at the monitor, and maybe we have a pediatric patient, and now you're able to say, uh-oh, I've got this pediatric intubated, and I know that my ET tube is too small. I know it's too small. So now I've got to make a big question. Do I extubate the patient? Do I truly extubate this pediatric patient to put in the right size tube? Well, let me tell you, this gives you the ability to make an informed clinical decision. It's not just yes, and it's not just no. You evaluate your patient. This is a tool. This is one tool of many. As a paramedic, man, I have a tool belt around my hip. And just like if I'm going to be roofing a house or doing carpentry or something, I'm not going to use a roofing hammer to do some trim work, and I'm not going to use a trim hammer to go roof a house. I mean, I'm going to use the tool that I need. So this is one tool that allows me to say, okay, my ET tube is too small. But is it effective? Is the tube that I have in right now, is it effective or is it not effective? That's what I need to find out, because if it's effective, I'm leaving it in. If it is not effective, I'm yanking it. It would be better to bag the patient with an oral airway than it would be keeping that tube in that's not effective. So I have to look at the rest of my tools. So I now look at the heart rate. I look at pulse oximetry. Is pulse oximetry okay? Is it above 90? I mean, if it is my patient pinkening up, or are they getting bluer? Are they getting more cyanotic? If they're pinkening up, pulse oximetry is going up, then I'm leaving the tube in. I'm going to the hospital and I'm saying, Doc, I have this patient. This is my 4-year-old kid. Pulled him out of a pool. And here's the vital signs. My end-tidal CO2, my capnography is this. The waveform shows me that my ET tube is too small. I know that for a fact. However, I chose to leave it in because pulse oximetry is 96. End-tidal CO2 is this. Heart rate is doing better. Child is pinkening up. So I believe that it's effective. I chose to leave it in. You do what you want. Instead of taking them into the hospital and the doc go, what size tube did you use? A 3? Oh, no. And yank it. And you're like, well, hey, hang on a minute, man. I mean, I work like ever to get that tube. Don't yank it. So you see what I mean? It now lets you, the doc knows that you made a good clinical decision because the tube was effective. It's a great tool, man. It's a great tool. All right, what's wrong with this waveform? It's got a little bit of a hiccup inside of it, right? That is a notched alveolar plateau. It's also called a curare cleft. If you use paralytics, if your system does RSI, then you use paralytics, you're going to paralyze the diaphragm. You're going to paralyze every muscle in the body, basically, except the heart, right? and out of that, you now have to breathe for them. Now, without having capnography, if I have somebody paralyzed, you know how I know to redose my patient? When they start bucking the tube, when they literally start chomping the tube and start bucking the tube, I know that my paralytic is wearing off, and I now need to redose my paralytic. This right here is a machine that before they start bucking the tube, when their diaphragm actually starts working just a little bit more, it'll hiccup. It'll actually give you a little bit of a contraction, put what we call curare as a paralytic. So it will give you a curare cleft in the alveolar plateau. That lets you know that your paralytic is wearing off and you need to redose your paralytic. Now, see how good that is for the patient? It's not getting them to where they're getting all uptight and everything and now coming conscious again. Remember when you redose your paralytic, we also resedate too. Boy, that would be horrible to have them just paralyzed and not sedated. All right. The other thing that it could be, though, is a pulmonary embolus. It's not a tilt. I mean, it's not always in a PE. It is not always in a pulmonary embolus. But if you have a patient who is truly showing signs and symptoms of a pulmonary embolus, and now all of a sudden you put them on capnography and they have a curare cleft, a notched alveolar plateau, then that's probably going to be a PE. And PEs, they're in pain. It may actually cause them to bump that diaphragm. We really don't know. We just know that it happens. And I asked Dr. Fowler, my friend, who's one of the medical directors in Dallas, Texas, and I'm like, why? Why, Dr. Fowler, does this occur? And that's the only thing we could come up with. So I'm just giving it to you out there as some information. All right, so there would be a sample monitor that has the notched alveolar plateau. That would let us know that our paralytic is wearing off. We now need to redose our paralytics and resedate. Another one. Here's a waveform. What's wrong with this waveform? It's got a little stair-stepped on there. What we call that is a stair-stepped alveolar plateau. And what this can indicate is the pressure of the expelled air is decreasing, allowing the oxygen to dilute the sample. One thing that can cause this is truly having, they're getting tired. I've seen this in the field, and when your patient is moving from respiratory distress to respiratory failure, you look at them and they look tired, and you ask them, are you getting tired? And they're just shaking their head. Would you like me to take over your respirations? And they're like this. Then that's what. You got a high flow oxygen running into this patient, and at the very end of their exhalation, they're getting tired, and it decreases the amount of CO2. It causes a stair-step type of alveolar plateau. So that's kind of the sample that you would give. Again, if you have CPAP on board, monitor your CPAP, because a CPAP may actually decrease the amount of CO2. If it's not working, bag them. Okay, if they're truly getting down to where they're fixing to go into a rest, then bag them. All right, here's a normal waveform, but as each breath goes on, it starts to increase. Now we've got this increasing waveform, and let's say that the respiratory rate is 6. Maybe it's a 40-year-old heroin junkie that just shot up black tar heroin, and now he'd wiped his respiratory rate down to 4 times a minute. So he still has to get rid of the same amount of exhaust, right? But instead of breathing 16 times a minute, he's now breathing 4 times a minute. So per breath, per breath, the CO2 level has to increase on that sample. So hypoventilation could cause a steadily increasing CO2 level. Another thing that could be is that your metabolic rate is increasing. I mean, you go run around this conference center and get your heart rate up to 148, you're increasing you're burning more oxygen, more fuel. When you burn more fuel, what happens to the exhaust? The exhaust increases as well. So that could be increasing CO2 level. All right, so we look at the sample monitor again, and per breath, we're actually seeing that respiratory rate's very low, right? Respiratory rate is like 6 times a minute. The pulse oximetry is 88%. That's low, below 90. And then per breath, that's the 17-year-old kid at a party that's unconscious and has a respiratory rate of 6, and everybody denies drug use. So what do? Well, we give oxygen. We bag them. If they're hypoventilating, bag them. Give them Narcan. Then we go to that whole treatment, right? All right, another waveform. Oh, all of a sudden, it decreased. I mean, it's decreasing per breath. So that's the opposite. That is hyperventilation. We now have a respiratory rate of 36. A 16-year-old female cheerleader at a football game sucked down a June bug. And all of a sudden, she goes from 16 times a minute to 40 times a minute. So by blowing off all of her CO2, because she's hyperventilating, her CO2 level is going to decrease. Or this could be a decreasing metabolic rate. Okay, so now we've got a parasympathetic nervous system effect, slowing the heart rate down, slowing the cardiac output down, slowing the CO2 production down. So what would we do? Again, oxygen, bag, calming measures. If your protocols say to start giving some type of sedative to decrease that anxiety, then that's what we would do. All right, another one. What is wrong with this waveform? That one decreased immediately. You understand that capnography is per breath. This is literally per breath, an immediate indication of what's going on your exhaled air. So all of a sudden it goes from normal down to low numbers. That could indicate a sudden drop in cardiac output. Maybe we have an MI patient. He now has an inferior MI with right-sided involvement. He had a blood pressure of 110 systolic. You give them 1 nitroglycerin. We drop his pressure down to 62 systolic. I now see it. I need to take a blood pressure, but I don't have to take a blood pressure to know that his blood pressure just dropped in the toilet. You see what I mean? So I see that immediately by capnography. All right, so we're looking at the monitor, 120, maybe, and it doesn't even show ST segment elevation in lead 2 because that one's not an inferior MI. Maybe it's in the V leads, maybe it's in the chest leads. But immediately we drop the CO2 level. I know that could be one thing, a sudden drop in cardiac output. So check a pulse, check a blood pressure. If he doesn't have a pulse, do CPR. Do something, maybe vasopressors. Do your shock management to get the pressure back up. All right, another waveform. Oh, we went from breath, exhalation, breath, to all of a sudden nothing. There's nothing there, man. That's the whole yikes type of, danger, Will Robinson, something's wrong. So we're breathing. Maybe that indicates that they stopped breathing, apnea. Maybe your tube became dislodged. It is an immediate indicator. Maybe the tubing became dislodged. Maybe it became unplugged. Some kind of equipment malfunction. What that's telling, maybe your patient died. They went into an arrest. It's just telling you that there's no CO2 coming out of the mouth, not coming out right here. Okay, so I immediately look at my patient. I immediately make sure that my tube is in. It's a great, perfect indicator for your intubated patient. ET placement, again, if you have square waveforms, then it has to be coming out of the lungs because look how the whole perfusion is taking place. It can't be this little bumpy type of waveform coming out of the lungs. That's not how the body mechanics work. And if it's there, nice square waveform, and you have your patient intubated, then it has to be properly placed. The ET tube has to be in the right place. So now we're looking at the sample monitor, and all of a sudden, look what happened. The guy went from a perfusing rhythm directly into ventricular tachycardia, and there's nothing. They're not breathing anymore because of the V-tach. I immediately now look at my patient and treat V-tach, whatever that is, whatever our normal treatment would be. Or if it is in the proper place, then maybe it's an equipment malfunction. All right, another one. Looking at that waveform, it was low, and down at about 20 millimeters per mercury, and then all of a sudden in an instant, it now went up to above who knows what. It could go above 100 if you want. Let's say that all of a sudden we have this person who's in VFib, and they're not, it's not perfusing, not getting much CO2 production, and then all of a sudden we defibrillate that patient. When we defibrillate them, they now start their heart back up. It now starts, it has maybe it has a pulse, but at least it's beating again, and now all of a sudden the CO2 level. Have you ever flooded a car? Have you ever seen a car flooded? And when you flood it, you finally get it cranked up again, and what goes out of the exhaust? Oh, this black soot. I pity the guy who's behind me, right? But now all that high black soot, same thing here. We just cranked the engine back up, and now that CO2 that has been inside of the body is now being flushed out. But does the car always have the black soot? Does it always continue for the rest of the car's life? No, it doesn't. It eventually all the soot goes away, and it goes back down to normal. So will the body. Okay, so will the body. But right there, I need to check a pulse. Right there, at that moment in time, when I see that on my capnogram, I now need to reach down and check a pulse because that guy's heart started back up again. So now, he may or may not have a pulse. It may be PEA. We look at the sample monitor, and look, this guy's in V-tach with low CO2. We now defibrillated that guy one time, and now all of a sudden he became into a sinus Brady type of rhythm at 50 beats a minute, and the end-tidal CO2 now just jumped up to 90 millimeters per mercury. What I need to do is check a pulse on that person. They may or may not have a pulse, but their heart's beating again. If they don't have a pulse, that is PEA. And then we treat our PEA with CPR, good ventilations, not hyperventilation, good ventilation. Epi is the first drug of choice in PEA because of the vasoconstriction and bronchodilation and all that other stuff. On the determination of death, okay, if you're doing CPR on somebody for 20 minutes and they're staying asystolic or whatever it is, American Heart Association says that if end-tidal CO2 remains below 10 millimeters per mercury throughout your entire resuscitative efforts, full ACLS stuff, for greater than 20 minutes, you need to pronounce them. You literally need to pronounce them. Make sure that it's not hypothermia. There's not other conditions. You're not hyperventilating the patient, overventilating them. But if you're doing everything right and all the conditions are good, American Heart Association says that if it stays below 10 millimeters per mercury, you can do a field pronouncement and leave that patient there because there's not anything that anybody can do to bring them back. Okay, it's a good indication for us. So we're looking at this monitor. Asystole, it remains asystole. We have maxed out on atropine. We've done all of our epi and everything else, and they've remained down low. They're still asystolic. I'm pronouncing that patient if my medical director allows me to do that. All right, my last little comment. Capnography is the best tool since the EKG. It not only helps you assess, diagnose, and treat your patient, it also allows to see if your treatment is working. So, thank you very, very much for attending this. I know Paul's coming back up here. I have some cards and some brochures on some of the business that I do if you're interested in more CE. But again, thank you very much.